Hi, all right. So this is a podcast on ideal surgery, NBME concepts, and I will be discussing some very important bullet points you need to know regarding the exam because, as I told you before, that the, the length of the questions on in USMLE Step 2 CK is pretty long. So what you need is you kind of have to have bullet point in a mind which you need to know for the diagnosis and the treatment, right? So let's discuss some of the points. So if you choose SITZ BATH as an answer, like when should you choose SITZ BATH as your answer? In which condition? It's most of the time in USMLE they ask in anal fissure, right? So additional to your stool softeners, you will be choosing SITZ BATH as an answer, right? And when do you choose anal fissure as your answer? Like what's the clicking point to choose anal fissure as your answer? Because question they will say in during physical examination it shows that the premium is showing an ulcer on the posterior midline of the anal canal, and you can also see a skin tag as well, perimeter skin tag. One of the very important descriptor in your question is if they say that the rectal exam cannot be performed because of very much pain and increased anal sphincter tone. So this should click you to choose anal fissure as your answer, right? When do you think hydrocortisone enema should be an answer? Most of the time it's in the IBD, ulcerative colitis. But remember this, for IBD, the first line treatment is always mesalamine, 5-ASA compounds. But hydrocortisone enema can be the answer as well in acute cases. When do you choose anal manometry as your diagnosis? In which condition you will be choosing anal manometry as your answer? So we discussed it in length when we talked about Hirschsprung disease in child. They say child passes one string like stool every 4 days, despite all the maximum laxative therapy, and there is no stool in the rectal vault as well. So you will be choosing anal manometry as your answer. And you know what's the confirmation? How do you confirm it? Biopsy. Biopsy is the most accurate, right? For hemorrhoids, they want you to know the placement of elastic bands as the first line of the treatment. It's most accurate in the USMLE. And what if you get a case in which a patient have a cystic mass at the top of gluteal cleft, like on the tailbone, you have a cystic mass. What is this? This is pilonidal cyst or pilonidal abscess. And the treatment of pilonidal abscess is what? Surgical drainage, just off the middle, and you remove it, right? How do you actually diagnose your GERD? GERD is, we discussed it again in medicine. We give trial of PPIs first, right? This is both diagnostic and therapeutic. But when they say, when is your 24-hour pH monitoring is your answer? So if patients already failed PPI trial, but they suggest that this is a case of GERD, so you will be choosing 24-hour pH monitoring in that case, right? And when do you choose endoscopic ultrasound as your answer? It's almost never. You know, they mention it in most of the time in pancreatic cancer. If you want to, if the CT findings are negative, you can diagnose it on an endoscopic ultrasound, and you can check metastasis with the endoscopic ultrasound as well, right? And when do you choose esophageal manometry as your answer? They want you to know that for eclasia, that's the best test, esophageal manometry. After barium or gastrographin enema swallow testing shows bird's beak appearance, you will be choosing esophageal manometry after that, right? So if let's say 40-year-old comes to you with the history of GERD, 3 year, 4 year history of GERD, and your chest x-ray, you did the chest x-ray and it shows air fluid level posterior to your cardiac select. What is this? This is hiatal hernia. This is hiatal hernia. And what's the next step you will be doing if you see this thing? You will be going for barium swallow. Will show your proximal stomach herniating through the esophagus, esophageal hiatus, right? So you said that barium swallow is showing hiatal hernia. What's the next step? The next step would be you will be doing esophagogastroduodenoscopy. This is what they want you to know. esophagogastroduodenoscopy. Right? So, okay, let's talk about some of ALP stuff. If you get a case in which the patient has high ALP with high direct bilirubin, with high amylase and lipase, what is it? This is a case of gallstone pancreatitis. Due to cholelithiasis, pancreatitis can happen because cholelithiasis can lead to high ALP, high direct bilirubin, right? So remember this. Second question they can give you is, if you see a case in which the patient has high ALP, high direct bilirubin, high amylase lipase, plus they will give you a case in which the patient has cholecystectomy. What is this now? This is a case of sphincter of Oddi dysfunction. They want you to know this because, you can't choose cholelithiasis, gallstone pancreatitis here because already the patient has had cholecystectomy. So in this case, the patient has sphincter of Oddi dysfunction, right? What if you get a case in which the patient has high ALP with high direct bilirubin and the normal amylase lipase in someone, the patient who already had cholecystectomy? So high ALP, high direct bilirubin with normal amylase lipase, already the patient had cholecystectomy. What is this? This is a case of cholelithiasis. Cholelithiasis. This is the retained stone in the cystic duct that descended actually, right? So cholelithiasis is the answer in this type of cases. How do you diagnose and treat cholelithiasis? Only ERCP. ERCP is both diagnostic and therapeutic here, right? Again, a very important thing, you should know that. If you see a case of high ALP with high direct bilirubin, plus the patient has normal amylase lipase, and the patient already had cholecystectomy already. Now, this might be a case of cholelithiasis. You can have, plus the patient, they can give you one more point here. They say that the patient has weight loss. Now, what is this? This is pancreatic cancer. And how do you diagnose pancreatic cancer? CT abdomen with contrast should be done. CT abdomen with contrast should be done. Right? Again, what if you get a case again with high ALP, high direct bilirubin, with normal amylase lipase in someone already had cholecystectomy, but in this case, CT is negative again. So this is not a pancreatic cancer. CT is negative. What is this? This is a case of cholangiocarcinoma. In this case, we usually might see a negative CT, cholangiocarcinoma, tumor of gallbladder. Right? If you get a case in which the patient has high ALP with high direct bilirubin, normal amylase lipase, right? Normal amylase lipase, plus the patient has diffuse pruritus and the patient has high cholesterol. What is this? This is a case of primary biliary cirrhosis. Primary biliary cirrhosis has both pruritus and cholesterol. Right? Again, if you again see a case of this thing, ALP, high ALP with high direct bilirubin with normal amylase or lipase, and they will give you the patient has autoimmune history already. Some of Hashimoto's or Graves or whatever the patient has autoimmune going on. Or the patient has autoimmune disease in the family. Again, you should choose primary biliary cirrhosis. And how do you diagnose primary biliary cirrhosis? First thing you have to do anti-mitochondrial antibodies. And the next best step you will be doing, you will be confirming it on liver biopsy. Right? So there are so many questions with the patient they can give you on high ALP. If you get a case in which the patient has recent cholecystectomy and now the patient is presenting to you with fever and abdominal pain, what is this? This might be a case of post-operative bile leak, can lead to fever and abdominal pain with a recent history of cholecystectomy. Right? If you get a case with high ALP, high direct bilirubin, normal amylase lipase, and CT is showing now cystic lesion in bile duct. This is a very important case in childhood. Cystic lesion in bile duct. What is this? This is a case of choledochal cyst. And what's the treatment here? You will be you will do simple excision of this cyst, right? Very important to know that a cholangiocarcinoma is not cystic. And In cholangiocarcinoma, you will not see anything on CT scan. So remember this is how you differentiate between cholangiocarcinoma and the choledochal cyst, right? How do you view your liver or pancreas? What's the best modality to view your liver or pancreas? If you get a case in which you have to choose, you have to view liver or cellular carcinoma for whatever reason, you will be choosing CT with contrast. For pancreas as well, CT with contrast. If you want to see acute necrotizing pancreatitis or chronic pancreatitis, whatever you want to see, CT with contrast is best one. How do you view your gallbladder? Most of the time it's ultrasound, right? If you get a case in which the patient has suspected cholecystitis and you did the ultrasound and ultrasound is negative, what's the next thing you will be doing? You will be checking for with HIDA scan. HIDA scan is used to check after ultrasound to see any stones, right? What type of imaging you think you need to view your bile ducts actually? The bile ducts you will be doing ERCP or MRCP, right? If they list both of them, ERCP or MRCP, choose ERCP because ERCP is sometimes both therapeutic and diagnostic, right? If you get a case in which the patient already had a history of ulcerative colitis, and now the patient is presenting to you with high bilirubin and high ALP, what is this? This is a case of primary sclerosing cholangitis. Very important to know this one as well, right? Okay. So, what if you get a case of a neonate with the old patient neonate? The patient has having jaundice with direct bilirubin. It's like 14 now, 15 now. Total bilirubin is only 16, 17. The direct bilirubin is 14, right? What do you think this is? This is conjugated hyperbilirubinemia. What is the cause, important cause in 8-day neonate with direct bilirubin? What is this? This is a case of biliary atresia. Very important to know. So next best step in the diagnosis, if they ask you, is you will be doing straight up liver biopsy here. Nothing else. If positive liver biopsy is positive, then go with liver transplant. This is must thing you need to do in this case. Okay, let's see. If you have a case, a 79, 80-year-old male comes to you with the history of atrial fibrillation, and now he's coming with acute, severe, diffuse abdominal pain. What do you think that is? This is acute mesenteric ischemia, mostly caused by thrombus embolizing from your superior mesenteric artery or inferior mesenteric artery, right? And in above 79-year-old, what's the next best step? If you are getting a case of acute mesenteric ischemia, you will be doing mesenteric arteriography. How do you treat? We will be treating with antibiotics. Like for necrotic bowel, you obviously have to give antibiotics and then you remove the necrotic bowel. Laparotomy to remove it, right? They actually give you this last line as a question, then IV antibiotics are administered, and what's the next step now? So you will be choosing laparotomy, right? So very important thing to know, treatment here is laparotomy. Sometimes they want you to choose embolectomy, but the only thing USMLE is interested in removing this necrotic bowel. So choose laparotomy as your answer. Right. Okay. So if you get a case in which the patient it's not in 80s, now it's the patient in 50s, and the patient had episode of ventricular fibrillation. We defibrillated this patient, and now the patient has severe abdominal pain. Again, this is a case of acute mesenteric ischemia due to ventricular fibrillation, not an embolus, not AFib, not an embolus. It's due to now mesenteric ischemia due to VFib. In this case, the patient, if it's stable, go to the CT and give antibiotics, and if unstable, the patient should go for laparotomy right away. Right? What if you get a case of a female who's diabetic and the patient has history of intermittent claudication, and history of abdominal pain too, 1 to 2 hours after eating meals. After eating meals 1 to 2 hours, the patient is getting pain. What is this? This is a case of chronic mesenteric ischemia, usually caused by atherosclerosis of your superior mesenteric artery and inferior mesenteric artery. Right? Essentially, this is also called angina of bowel as well. And in this case, okay, so if you get a case in which the patient is again same case, 55-year-old with diabetes, and the patient had history of cabbage now already, and now the patient is presenting to you with acute abdominal pain after eating meals, 1 to 2 hours after eating meals. What is this thing? What's the next step you're gonna do? You will be doing mesenteric arteriography. Check for ischemia. Again, if you get a case in which the patient is diabetic and the patient has a history of renal artery stenosis, and the patient has history of abdominal pain as well, 1 to 2 hours after eating meals, what's the treatment here in this case? We already choose diagnostic mesenteric arteriography. So if the arteriography works, what's the treatment? The patient should go over angioplasty and stenting to restore the blood flow there. Right? What if you get a case in which the patient is chronic mesenteric ischemia, as the patient has 2 days history of abdominal pain with fever? What is this? This is a case of acute mesenteric ischemia on chronic. Acute on chronic can happen due to thrombosis. Right? So the same thing, mesenteric arteriography to diagnosis and to treat, you will be going antibiotics and nephrotomy to remove the necrotic bowel. So I guess this is it. This is all of it. I'm going to discuss again with the next podcast. I will be sharing you soon. That's it for now. Hope you liked the session, and thank you.